Cool. Thank you so much for inviting me to speak here today. It's a real honor, and it's just wonderful to be in an in-person conference again and just be able to look out at a sea of unmasked faces and remember the old days. So um, I'm just going to kind of move to our slides here and kind of begin the talk. So I'm here today to talk about Premise Health's Beyond Weight program. And this is a program that's aimed at addressing the growing obesity and overweight epidemic within our worksite centers. A little background on myself. I'm a family physician. I'm also boarded in obesity medicine, and I serve as a site director for the program as well as a clinical advisor. And with me is Dr. DiNardo, who's the medical director of our site. So what is the Beyond Weight program that I'm here to talk about? Well, put simply, it is a primary care-led, comprehensive, and longitudinal obesity management program. So what does that really mean? Essentially, what we're doing is we're creating a program to empower our primary care providers to serve as obesity experts for their patient panels. And why this is so important is the fact that traditionally, the management of overweight and obesity has virtually been non-existent. When you think about when patients say, I went to a weight loss clinic, most oftentimes they're talking about like a cash based system like a Medi weight loss, or in more robust systems, you'll actually see, obesity management programs that are usually structured in a very central way with a few obesity experts, support staff that is in charge of managing overweight and obesity in a large population. And the reason this is a fundamentally flawed structure is a simple fact that 70% of our patients, no matter where you work, are going to have overweight or obesity. Put another way, there are more adult Americans with overweight or obesity than there are men or women. So clearly, we need to expand access to care for this growing population. So that is the focus of the Beyond Weight program. So I'm just going to give a quick overview. I'm going to just go over the obesity epidemic. I'll try to move through that fairly quickly so we can kind of pass the mic on to Dr. DiNardo to discuss the actual rationale behind creating the program. After that, I'm just going to go into the nuts and bolts of the program and how it's structured. And finally, Dr. DiNardo is going to take us home with some future directions and final thoughts. Okay, so defining obesity. How do we define obesity? This is important. And traditionally, we use the BMI model, right? If you look at most medical literature, if you're into that, very commonly we define it based on BMI, which is really just a ratio of your height to your weight. And we range it all the way from normal weight to overweight, all the way to class 3 obesity, which is a BMI greater than 40. However, we all know that there's limitations to this model, right? Like a classic example is an NFL linebacker. Yes, they are obese by BMI metrics, right? But metabolically, they're fitter than myself and I imagine most everyone in this room. On the flip side, you can have someone who has normal weight who is metabolically obese. Think of a desk worker who's very low muscle mass, has a central kind of paunch on them. While they may not meet criteria for obesity based on BMI, metabolically and health-wise, they are very much obese, right? So there are other models that try to kind of bridge that gap, looking at things like waist circumference, body fat percentage. But fundamentally, these don't really define obesity. They more just characterize it, right? In the Beyond Weight program, we really abide by the chronic disease model, which basically states obesity is defined as a chronic, progressive, relapsing, and multifactorial neurobehavioral disease. Why this definition is so important is because traditionally, obesity is not really seen as a chronic disease, but rather a characteristic that we assign our patients. We say we have a patient that is obese. We have a patient that is overweight. This is not particularly helpful because in many ways it can be off-putting and it can kind of alienate patients first off. And secondly, it doesn't recognize obesity for what it is. a true chronic disease. In the Beyond Weight program, we actually say our patient has overweight, our patient has obesity. Because again, we want everyone to be aware that this is a chronic disease, just like high blood pressure, diabetes, and hyperlipidemia, and it should be managed as such. This is a very simple graph, just looking at the prevalence of obesity in the United States. This is kind of old data. It's off the CDC website. It's from 2020, so this is pre-pandemic. But the bottom line is 40% of American adults have obesity and 70% have overweight or obesity. And also, it's important to note that this number is changing with time. In fact, particularly in the class of severe obesity, those numbers have doubled in the last decade. I think we all know that there's a tremendous health impact surrounding overweight and obesity. I think even most lay people are aware of the fact that it's associated with chronic diseases such as chronic pain, heart disease. I think a lot of people are surprised to find out that there's a growing list of cancers that are attributable to overweight and obesity. And in fact, there's some estimates that estimate about 40% of cancers in the United States are attributable to overweight and obesity. And there's also the financial impact. Now, I'll admit this is not my area of expertise, but I think a picture says a lot, right? And this is actually from the Journal of Occupational Medicine. This is from the Optum's Health Claims database. And the bottom line is there is increased costs with overweight and obesity, particularly in that severe obesity range and or class 3 obesity, where in this study, they actually showed per person per year an increase of just direct healthcare cost of $11,000 per person. Right. And this doesn't even factor in the more nebulous things such as absenteeism, presenteeism, which are a bit more difficult to calculate. So we understand that it's a problem. So what can we do about it? And I think this is a very important slide because it shows the impact of managing overweight and obesity. So you see on this slide, with a weight loss of about 3 to 5% of body weight, we can actually prevent a chronic disease from happening. So think preventing prediabetes to diabetes. At a 10% weight loss, we actually see improvement in the numbers around chronic disease. So think improved blood pressure, improved blood sugar. At 15% weight reduction, we actually see reduced cardiovascular risks, which we all know is the #1 killer of Americans. And it's really that 20 to 25% range that we're really shooting for, where we actually put chronic disease associated with overweight and obesity into remission. So we know it's crucial that we're treating overweight and obesity, but the question is, are we? And I apologize, this slide is horrible. It's really busy and painful to read, but the bottom line is this. This is taken from the NHANES study, which is a very well-known study that's been around since the 1960s, looking at the health and nutritional status of Americans. And the bottom line is between 2015 and 2018, of all the Americans who were candidates to be treated medically for overweight or obesity, only 1% were receiving a treatment. I'm going to say that again, 1%. Imagine if you operated a clinic where patients with hypertension and diabetes were coming and only 1% of them were receiving treatment. I hope that clinic would not stay open for very long. So with that being said, I'm going to turn it over to Dr. DiNardo, who's going to talk a little about the actual creation of the program.
Great. Thanks, Dr. Gineris. Absolutely. Yeah, as Dr. Gineris explains, the rising prevalence of obesity and its complications placed a significant burden on patients, their employer, and the healthcare system. And as he explained earlier, when 70% of the patients we're seeing in a health care center have overweight or obesity, it's essential we recognize this and offer treatment. I want to draw attention to the terminology we used, as Dr. Gineris again explained, that as we describe overweight and obesity, we explain this as a chronic condition rather than a pejorative label. This helps the provider, again, create more of an environment that provides support and allows the patient to be more receptive to understand this condition, accept treatment, all while not downplaying the seriousness of their condition. There are several treatment approaches for weight management. And at Premise Health, we've created a series of guidelines put together through a number of our providers so that any of our care team members can provide this when navigating this treatment with our patients. We find that this is best led through the primary care provider and that this is best empowered through a patient-centered medical home. We recognize obesity as a chronic complex disease, and by combining the tenets of lifestyle medicine and the best evidence practice guidelines in the field of obesity medicine, we aim to create the gold standard for a comprehensive obesity management program. Our care philosophy at Premise Health is built on lifestyle medicine. This involves approaches targeting lifestyle habits, including nutrition, physical activity, emotional well-being, restorative sleep, proper hydration, avoiding harmful substances, and getting outdoors to prevent, treat, and reverse chronic disease. This approach is so important because rather than just treating symptoms, this helps us really treat the root cause of so many medical conditions we see every day. And backed by over 50 years of scientific research, it's clear to say that this approach is safe, less costly, and more effective. Because lifestyle medicine is rooted on health behavior change, we ensure all of our providers are trained on techniques to work with their patients through this. Through skills such as empathic listening and open-end question dialogues, it really does create that environment, not just to engage patients once, but to keep them coming back, to keep them engaged in their treatment. The care team model that we use is centered around the patient and the primary care provider. An interdisciplinary team then supports the patient where they need it most. Staffing may differ from health center to center, but we find that 6 key roles tend to work best in this model. Through the behavioral health pillar, members are taught to develop a healthy self-esteem and to work through barriers that may have prevented success in the past. In the event that mental health disorders are present, interventional counseling is offered to help overcome this. The clinical pharmacy pillar is essential. This really supports members with education and support when it comes to their medications. Assistance with prior authorizations and refill reminders are ways we help improve medication compliance. Also, education just on the medication or even training how to use it, such as some of the injectables, really empowers patients to be an active participant in their treatment plan. And through the wellness coaching program, which is just as important as any of these, it really helps the member formulate a winning perspective. We understand in life things can happen and it's easy for us to lose track of personal goals. Health coaches really have periodic routine check-ins just to keep members on track. And in the event something does happen to pull them away, helps guide them back into the program. Additional pillars include physical activity, nutrition, population health, and we'll touch on those in later slides. Our Premise Health team is also skilled on screening for social determinants of health, and more importantly, how to navigate members to available resources. This is important. Some of the situations we encounter are individuals having food insecurity or financial difficulties. And when we're coaching them on how to, or the importance of buying and using fresh vegetables, it could be difficult for them to afford that. So we sit with the member, we identify community resources, even coupons at nearby grocery stores to support this. Another one that we commonly encounter are transportation difficulties. Instead of telling the member to get in their car and go to a gym 3 or 4 days a week, we work with them to identify a game plan that is feasible, such as riding their bicycle, walks through their community, or even exploring online virtual exercise platforms with them. I'll now turn it back over to Dr. Janarius, and he'll explain how our care philosophy aligns with the Obesity Medicine Association treatment algorithm, and also a little bit more details about the pillars and protocol itself.
Thank you. So yeah, essentially in this program, what we're doing is we're combining the tenets of lifestyle medicine with the Obesity Medical Association's obesity algorithm. And this is a publication that comes out. It's edited every year, and it basically gives the guidelines for how to manage overweight and obesity. And as you can see on the bottom, they have 5 fundamental pillars, right? There is nutritional intervention, physical activity, behavioral therapy, pharmacotherapy, and bariatric procedures, bariatric surgery. Because I did not want to do the extra 4 years of residency to be a bariatric surgeon, I narrowed it down to 4 pillars. So I'm going to kind of walk you through these 4 pillars and what they mean in the context of our program. So nutrition, again, nutritional intervention is fundamental to the management of overweight and obesity. And we do acknowledge the AHA guidelines published in 2013 that largely focus on creating energy deficits, energy restriction as the part of the management of overweight and obesity. However, from the lifestyle aspect, we really bring in that focus on the whole food, plant-based diet and really stress this should be the foundation of our patients' diets and the foundation of their nutritional intervention. Why? Because there's abundance of evidence showing a plant-based diet is effective in preventing and treating chronic metabolic disease. In addition, we do encourage adequate protein intake, and that's to prevent muscle wasting during the weight loss process. Adequate hydration is a kind of a no-brainer. And, we really focus on using evidence-based culinary medicine. And certain sites, we are fortunate enough to have registered dietitians and culinary experts to assist with our more complicated patients. But in most cases, this can be managed largely by the primary care provider. With regards to physical activity, again, we give a nod to those AHA guidelines that talk about 150 minutes of activity weekly for the management of overweight and obesity. But we also focus on other realms. There's a concept called NEAT, which stands for non-exercise activity thermogenesis. And that's just a fancy science way of saying all the things you do in your life that are not intentional exercise. So that's going to the grocery store and shopping, doing the dishes, taking the stairs instead of the elevators. These have actually tremendous role in the management of overweight and obesity. We definitely reinforce the role of strength and mobility training for longevity and quality of life. And at select centers, we are blessed to have exercise physiologists to help with our more complicated patients. Again, with behavioral health, super important in the management of overweight and obesity. Every intake that we have with our patient includes a comprehensive mental health screening that's repeated at every visit. As Dr. DiNardo touched on, we focus in on those social determinants of health. And a really cool program we have within Premise, the Behavioral Change Generalist Program, is actually used to train our providers in the art of motivational interviewing, which is crucial to the management of overweight and obesity. And we do have a monthly curriculum that we hand out to our patients with every visit. And lastly, medication management. And this is an area where there's obviously huge room for improvement, but we've been doing a great job of it so far. Now, we focus very much on using FDA-approved medications or anti-obesity medications, but we also use off-label medications when appropriate. In terms of medications, we do put a lot of emphasis on de-escalating medications and devices when appropriate. So once we treat, the goal of treating overweight and obesity is to put metabolic disease in remission, right? So once their diabetes is in remission, their hypertension is in remission, we start taking away those medications. It takes a burden off both the patient as well as our clients. And we are lucky to have on-site pharmacy available to assist with that, to assist with patient education, as well as annoying prior auth forms and things of that nature. Okay, so let's just take a little look at the protocol itself. So this is just some basic inclusion criteria, and this is largely based off FDA recommendations for medical therapy for overweight and obesity. And we do have a few exclusion criteria listed below. Generally, in our protocol, we have 3 visit types. We have an initial intake visit where you really get to know the patient, a follow-up visit shortly thereafter where we create a medical weight loss plan for our patients, and then monthly follow-ups after that. So the intake visit is personally my favorite as a clinician because this is really where you get to know your patients. It is a 20-item comprehensive assessment that we've actually built into our Epic EMR, such that it can be accessed by any provider with a click of a button, and it just walks you through the questions. And it's great because as you do this, you really get to know your patient, and trust me, they tell you everything. And at the end of it, we order some baseline labs that we use to monitor metabolic parameters, and we repeat those at quarterly intervals throughout this process. And what's super cool is we actually have an internal referral system such that we can then put our patients into data tracking and population management. The next visit is the medical weight loss plan visit. This usually occurs 1 to 2 weeks after we do our intake. And this is basically where we create that 4-tiered plan based on the 4 pillars of obesity management. In our center, we do use a machine to break down their body composition as well as metabolic needs that helps us tailor therapy to the patient. We do have them sign an informed consent and a patient agreement form to be in compliance with state laws. And at the end of the visit, once they've gotten their plan, we make sure to schedule them that before they leave to have a monthly follow-up with their Beyond Weight provider so that we don't lose them to follow-up. And the follow-up visits are just that. Basically, we walk the patient through those 4 pillars over and over and over again, and we adjust the plan as needed till we get the patient to their goal. And again, once we get them to their goal, 2 things. One, as we discussed before, we really try to de-escalate those medications that are no longer needed and those devices that are no longer needed. And we also emphasize that, again, that even if they've achieved their goals or remission of certain metabolic diseases, we do encourage them to remain in the program because, again, this is a chronic condition. Just like you don't see your diabetics for 3 months, see their blood sugar get better and say, adios, good luck to you. We make sure that our patients come back to us. Okay, with all that said, I'm going to turn the mic over to Dr. DiNardo, who will take us home with some future directions and final thoughts.
Great. As well other fields of medicine, the way we treat and view obesity will continue to evolve over time. A few near-term initiatives we've been working on. First starts with expanding access through the care team. We really encourage all of our providers really to take any type of training opportunities in lifestyle medicine, as well as expanding their knowledge in obesity management, just again, because of how prevalent this is. Additional roles we plan to incorporate into our care team as well include certified medical interpreters, really to improve members' experience if English may not be their first language. Additional nutritionists and even teaching centers, teaching kitchens, really to improve access again to patients and their families, to really emphasize the importance of nutrition and teach them how to cook these meals at home, as well as population health coordinators. They're able to really, as Dr. Gianaris explained, help us track the patients in these programs and identify populations that may be best vulnerable and really benefit from the program that we can outreach to them. They also help with our data tracking, just to ensure that as we move forward in the future, that we really optimize our processes to ensure results are seen. Additionally, delivering services virtually. We've done a great job of this over the last 3 years and can pretty much offer any primary care service virtually at this point. We're working on ways to also deliver weight management, but to do it well, not necessarily to kind of lose track or data points with patients, but really to make sure that things are moving in the right direction and that we ensure all levels in that care team model are focused on. Leveraging technology. The COVID-19 pandemic has certainly been a catalyst to the way we use technology in primary care. Currently, we're using smart home blood pressure monitors and activity trackers that integrate with our health records. Additional tools we're working on include smart scales that provide body analysis, as well as smart measuring tapes to track changes in body part circumference. These hopefully too can integrate with our records just to keep that additional subjective or objective data coming to our providers to adjust and modify treatment plans as needed. Also too, there's a lot of research in the field of obesity medicine. Epigenetics has been a great direction, and hopefully as more of this published information becomes available, we hope to incorporate this in our protocol, really to strategize the way we're using diet programs, exercise programs, even medications. And lastly, support groups. Probably my favorite part of being a provider, and I could probably speak for Dr. Gianaris on this too, is really watching members succeed in their health journeys. In addition to celebrating this triumph with the member, we encourage them to share these success stories with their families, friends, even coworkers. So as we identify more national, local, even worksite support groups, these are ways to keep them motivated to maintain that progress and also to motivate others so that they can actually join in the program and fight for their healthiest selves as well. In conclusion, we would like just to, again, thank everyone for allowing the time to speak, and we hope you found this educational and even motivating. If there's any questions, we would be happy to answer them at this time.
Before we go, does the provider visit or does another? Yeah, at this point, actually, it's definitely the provider. We have thought about streamlining the process, and we keep that in the back of our mind. But it's for the patient relationship. That intake visit is so crucial because I mean, I'm not going to obviously bore you with the details of what the intake entails, but it is really how you get to know these patients. And after that intake visit, they really become yours. A lot of, as primary care doctors, we have thousands of patients on our panel, a lot of whom we know when they break something or when they get a cold, right? But when you do the intake on these patients, you really know them and they really become yours.
And lastly, what kind of outcome data do you have on the weight loss program?
That's a great question. So we launched in actually March of 2021. So we're still compiling data. However, I will say I have my own cohort of about 20 patients, pre-pilot patients that I kind of base the program on. And in those patients, we're looking at an average weight loss of around 17% per patient, reductions in systolic blood pressure of about 10 millimeters of mercury, reduction of diastolic pressure by about 6, and improvement in triglycerides of about 50 points. And there will be plenty more data to come in the new year. So,
Thank you. Another question. It was mentioned there's an Epic template for this work. Is there also a template that the patient uses to upload the data?
So we have within and I'll actually turn this over to Tony because this is his wheelhouse. But we do have a system called a flow sheet system where we can actually incorporate data virtually. So, for example, we have scales that link up to our health system so that when they step on the scale, it'll record their weight, or when they record their blood pressure, it'll actually record it into their chart. And that's one of the ways in which we're expanding our virtual care.
Exactly. And just as Dr. Gineris explains, the importance of that intake visit is vital. It really helps us understand questions that patients may not answer appropriately on some of these forums. So the template that we designed, even partnering with some of our behavioral health specialists, really hones in to identify those key questions that sometimes gets missed when we're seeing the individual for blood pressure or diabetes. We are working on some templates to try to gather some additional information that could be helpful, specifically looking at what some of the available resources they have, and that can help target a lot of our treatment plan as well.
Great. And lastly, I don't notice a surgical bariatric option. That's not included.
So yeah, so unfortunately, as I said before, I didn't have the time, but actually that is an important point. And for anyone who's a clinician out there, I never discourage anyone from getting bariatric surgery, and I never make them feel as though they failed if they go that route. That is one of the important pillars of management. And bariatric surgery, the data is unequivocal. It saves lives. So I never discourage a patient. Now, I will say I have had some patients that have come to me and said, I want to see a bariatric surgeon. And I said, that's fine. I will manage you while you do your pre-op, because anyone who's gone through bariatric surgery knows that there's a long pre-op process in which you work with dietitians. And I'll co-manage them while they prepare for surgery. I've had some patients that have done so well just with medical management, they actually drop out of the surgery. For my patients that go through the surgery, what I tell them is, come talk to me in 6 to 12 months after the surgery, because that's when you're at risk for that weight regain, right? And that's where, again, this is a chronic disease. that's a fundamental issue that I've had with the way bariatric surgery has been done in this country. Is so frequently you talk to a patient that goes in for bariatric surgery, they see their surgeon for 1 or 2 post-op follow-ups, and then they never see him again. Why would you do it? It's a chronic disease. You have to be managing these patients longitudinally. So if you go bariatric surgery, you have my support and my good wishes. Talk to me 6 to 12 months.
Great. Thank you very much. Thank you. Would you repeat that?
So that's a great question. So, and there actually is a very interesting paper that actually looks at what's called phenotyping your prescription. So in other words, there are certain patient populations that respond very well to different types of medications. So we don't only use one. I will say the most robust data comes from the semaglutide medications. But we use a whole variety. We use the full gamut, and again, sometimes off-label. But I would say semaglutide is easily our most popular, and to be quite frank, it's the easiest to use from the provider side because there's so few contraindications. I don't think I've ever met anyone with multiple endocrine neoplasia syndrome. Or maybe one back in medical school, but I doubt it's going to happen again. Knock on wood. So. Yeah, I mean, and again, it's one of these things that I get that a lot, but no one bats an eye when you prescribe semaglutide for diabetes. And again, this has to come with this sort of puritanistic way we approach lifestyle disease, where we put the blame on the patient. Yes, it's more expensive, but as we see, the cost of overweight and obesity is immense too. And we don't use that same calculus when we talk about other diseases, so I try to avoid that, but of course I do keep in mind if there is a cheaper alternative that I think based on a patient's phenotype will work better, of course I'm going to go with that.
Great. Let's thank Tony and Anthony. I'd like to turn over to Colleen. You can't see from there. Sorry. The controls over there.
Well, good afternoon, everybody. In the home stretch, and it is such a pleasure for me to be here today. My name is Colleen Smith. A little bit about myself. I have my Doctor of Pharmacy degree, and I work in medical affairs at AbbVie. And one of my areas of focus is migraine. But prior to coming to AbbVie, I actually worked for one of our nation's largest health plans, United Healthcare. I think you guys might have heard of them, and OptumRx. And in my role there, I led a team of pharmacists who supported employer groups. And so I am very familiar with the challenges that our employers face, and also had the opportunity of working with several employers who also established on-site or near-site clinics. And so for our discussion today, as mentioned, my focus is migraine. And I'm going to go a little bit of a route to share a little bit about the disease, but also share with you an experience that I had in partnership with a large national clinic vendor. Around 2020, the vendor mentioned to me, hey, I'm seeing a lot of drugs that patients are coming in that I haven't seen before. Some of you may be well aware, based on your pharmacy data, that we've had a lot of new medications that have been approved in the past 6 years. We've had several medications approved for the acute treatment of migraine and several approved for migraine prevention. And they said, we have algorithms for treatment in our clinics. We don't have these new medications on there. In addition, one of the things that they had mentioned to me was that primarily what they were doing at that point in time is that if someone came into the clinic, primarily what they were doing was providing a recommendation for an over-the-counter drug or possibly a triptan. But if a patient happened to be, really disabled, they really didn't get involved in migraine prevention, or if the patient was really having a very severe migraine, they actually referred them to the emergency room. And I don't need to tell you that that is certainly not an ideal approach. And so we embarked on a partnership to provide education to their advanced practice providers, also partnered with them to provide them with information regarding the updates to the American Headache Society consensus statement on migraine treatment algorithms. And they utilize that information to update their treatment algorithms and incorporate migraine, and not only just that very segmented approach where it's just, I'm going to recommend an OTC or a triptan and then send you off to the emergency, but really thinking about managing migraine, the disease completely from acute to prevention within the clinics. And it started with reviewing some of this data here. And so one of the things we went through was really that impact of migraine and what it has on the quality of life, families and relationships, as well as migraine-related disability. And we know from, these are stats from different surveys, and there are many surveys, but they all say the same thing, is that migraine's impact is really significant on someone's life. It's not just that individual person themselves, it's the impact to their families, it's the impact to their professional lives. And we see that 64% of people said that it impacted their private life, 70% of people said it impacted their professional lives. And some data from a Truven Health analysis that was published in Headache in 2018 noted that there were 8.9 more lost workdays for people with migraine versus people without migraine. And those lost workdays included absences as well as short and long-term disability. And also noted that patients with migraine often have coexisting anxiety and depression. So also diseases that can significantly impact and also cause disability on their own. We also looked at with them the impact of migraine in people who have 4 or more headache days per month. And so you're probably saying, why 4 or more? Like, what's so special about that number? Well, the American Headache Society does recommend that if someone has 4 or more headache days per month, that that person should be on a migraine prevention drug. And why should they be on a migraine prevention drug? Because they're having too many migraines. And so they really need to reduce the frequency and severity of those migraine attacks. And this is data from a health and wellness survey. And patients noted that when you look at work productivity, there was 5.5% higher absenteeism, 18.5% higher presenteeism. When you looked at healthcare resource utilization, they were having more healthcare provider visits and more emergency room visits. So the data is there to show that there's more emergency room visits. And as I mentioned, this clinic vendor said to me, we don't really have an updated algorithm. So if it's really bad, we're just telling people to go to the emergency room. And that ultimately translates into much higher costs. In this analysis, a little over $18,000 in annual costs for both indirect as well as direct costs. And so what about the prevalence? The prevalence of migraine is about 12.3% of the population. But when you look at the prevalence in our workforce, that number really jumps up. Migraine is the 3rd most prevalent disease in our workforce, and that's because of when migraine tends to impact someone. It's more prevalent between the ages of 20 to about your mid to late 40s. And so those are really our prime years for work, as well as everyone's growing a family at that time. So migraine really has a really significant impact on your life during this time. There are two types of migraine: episodic migraine, which is what most people have, 92% of people, and that's when you have 14 or less headache days per month. Uh, Patients who have chronic migraine, unfortunately, those patients are getting 15 or more headache days per month. So very significant impact. And so what is migraine? How is it defined? I think most people, when they think of migraine, they think just about that migraine attack that the person is having. That's only just one component of the migraine disease. There's actually 4 phases of a migraine attack. The first being the prodrome phase, where people can have sensitivity to light and sound. They can have difficulty in speaking and reading. And then about 25 to 30% of the population experience aura. And that's where they can have visual disturbances, temporary loss of sight. And then you get into that actual migraine attack phase, where some patients have described it as, really having an ice pick to their head. They may have coexisting nausea and vomiting. And then once that migraine is over, it's really not gone, because now someone's in that post-drome phase. And that can last, 24 to 48 hours, where patients are noting that they have an inability to concentrate, lack of comprehension. And when you think of the treatment of migraine, patients don't have to wait until they're actually having a migraine attack. If they can learn about their triggers and they learn about their symptoms that they're having before they have that migraine attack come on, patients can actually be treated in that phase to help stop that migraine attack and really prevent it from progressing. And so, when we were talking to that clinic vendor, they thought, okay, wow, not only should we be incorporating, updating our guidelines, but we need to educate patients that come in to learn about their symptoms. Because if they can treat their attacks early on, maybe we can actually impact some of that, those concerns as it relates to presenteeism and absenteeism. If we can get someone who comes into the clinic and they're having an attack, and we can provide them with appropriate treatment, maybe that attack will actually stop and they can actually go back to doing what they want to do. And so when you look at treatment, there are 2 types of treatment. The first, as I mentioned, is acute treatment, which someone can take just prior to the migraine attack occurring. Again, if they're aware of what those prodrome symptoms are, or they can take something to stop or reduce the migraine attack. It doesn't prevent it, but you can use it to stop or reduce the pain. And then there are preventive medications that are taken to reduce the frequency, severity, and duration of migraine attacks. And again, it's just having that understanding the both components of treatment. As I mentioned, the clinic, before we embarked on this education program, their efforts were really primarily focused in that acute phase, just to address the attack that the person was having. And if they were really disabled, that's when they were saying, gosh, I think you should just go to the emergency room. So they updated their guidelines to incorporate that full treatment of migraine. So diagnosis was key. And that was something that they really needed to update their treatment algorithms with. And there is diagnostic criteria that is available. This is diagnostic criteria from ICHD, as well as Migraine ID. And what they did is they incorporated this diagnostic criteria in with the information that's with their e-prescribe vendor, so that when they were seeing the patients, they were able just to go through this diagnostic criteria to determine whether the patient had a migraine attack. In addition, there's also diagnostic criteria to identify whether this is a primary or secondary cause of migraine, and that was also something that they incorporated into their updated treatment algorithms. And one of the things that's really very interesting and really kind of sad with migraine is that, only about 56% of people with migraines actually get a diagnosis despite having all of the conditions to meet that criteria for migraine. And there's been a lot of studies that have looked into why people actually don't have a diagnosis, and it's for various reasons. Sometimes people are misdiagnosed, they're underdiagnosed, and sometimes it's patients themselves. We've heard from patients that they say, I just thought this was something I had to live with. I didn't realize there was actually something that I could use that could help with my disease. There's the stigma of migraine. A lot of people think I just need to power through it. And so really education is a crucial part of managing the disease. One, to help patients really understand that there's treatment options available, not only from a pharmacologic standpoint, but there's a lot that can be done with education and understanding their risk factors and their triggers for migraine attacks. And so, as I mentioned, yes, there are lots of risk factors for migraine disease progression. And unfortunately, migraine is a disease that if it is not managed appropriately, it can progress from episodic migraine to chronic migraine. And there are some risk factors that are just can't do anything about. More women get migraine attacks. That age group that I mentioned, in your 20s, to your 40s, lower socioeconomic status, being previously married is also a risk factor for migraine attacks. But there are many modifiable risk factors, such as obesity, smoking, caffeine intake. And one of the things that the vendor mentioned to us that this was, they really saw an opportunity is that they really saw a way for them to not only manage migraine, but to point the patient to other health and wellness programs that they already had access to, that maybe they weren't using, that they didn't even realize that not only, is my smoking a bad habit, but it's also contributing to my migraine attacks. And so they already had a smoking cessation program that maybe they weren't taking advantage of. And so that's why it's really important to educate patients on those risk factors that are available. And again, how that ties into the already available health and wellness programs for members. Another really important risk factor is medication overuse headaches. Again, I talked about that stigma and people wanting to power through the disease. A lot of patients don't realize that some medications, if you take them too often, they actually cause migraine attacks to worsen. And so it's really important for them to be aware of that. Because if you are able to manage these risk factors, what the data has shown is that you are able to reduce the headache burden, reduce that potential progression of migraine from episodic to chronic migraine, and potentially the patient would go into remission. It's another thing that when we were going through the program, they thought it would be really good to understand, kind of what are the features of a patient with migraine. What do they typically look like? And so I'm not going to go through all of these, but as you can see, chronic migraine is definitely more severe in terms of the number of headaches, the duration, the severity of the pain. But one thing that they did incorporate into their treatment algorithm is that MIDAS grade. And MIDAS is a migraine disability assessment tool. And it has its grades 1 through 4, 4 being the most severe, meaning that migraine has significantly impacted someone's social and work life. And you can see, even with episodic migraine, about 1/4% of patients are still indicate that they are severely impacted with migraine. And of course, that translates into much higher costs and also much higher emergency room visits. And so when you look to really thinking about an approach to managing migraine, it's really a multifaceted approach. Education is really crucial. It's really important for patients to understand the disease, to understand what their risk factors are. Understand what lifestyle modifications can they make. Again, can they stop smoking? Are they overusing some medications that can cause medication overuse headache? And then making sure that there's appropriate treatment options available. I think a really good example of another success story in the migraine management approach is Metro Nashville Public Schools. I think I know a lot of you know Metro Nashville Public Schools. In 2020, they embarked on a migraine education program for their employees. And it was a 12-week program, and they offered, videos to provide. It was like 4 videos that provided information on the disease, again, to provide that education so that people understand the disease, understand what their risk factors, understand how they can take control of their lives. They also had access to 2 webinars where they were able to obtain live information from migraine experts as well as educational resources. Metro Nashville Public Schools, they did do a survey pre and post, and they had very successful results with their program. They noted that patients indicated that they felt that they had improved productivity after they went through the program. They noted that they had an improvement in the severity and the duration of their migraine disease. And more patients indicated that they were using appropriate acute treatment medications for their migraine attacks. And so that I feel like that program really encompasses the full spectrum of migraine management approach. AbbVie also has a program for our employees as well with the Migraine at Work, which is a very similar program. And we actually partner with Premise Health and have an on-site clinic where we do provide education about migraine. And so that is the conclusion. And I'm just going to include my contact information there. If anyone would like a copy of the presentation, I would be happy to send it to you. If there are any questions.
Any questions we have for Kelly? Do you have sleep areas or quiet areas at work for people to go? Is that recommended?
Yes, that is absolutely recommended. Our on-site clinics have just launched, but that is something that is absolutely recommended as one of the tools to help patients at work so that they have an opportunity to go somewhere that's quiet, close their eyes, get help at the on-site clinic, and hopefully don't need to go home.
Thank you
All
very
right.
much.
Thank you.
Thank you. And now Nicole, please.
Nothing like standing in your way between the door, the night, and everything else. So I had talked to Larry earlier today, though. I think that what I have kind of summarizes and wraps everything up with a bow. So I do present from a different perspective than most of the rest of the speakers today, in that I run the internal clinics for Pfizer. So I oversee all of our internal clinics. I am a Pfizer employee, and all of our clinics are run by Pfizer employees. So the one difference is we don't have primary care as a result of that, but we do episodic care. I have 13 clinics in the US, and I have clinics all around the world that service our 80,000 employees in 80 countries. So that is where my expertise comes from. But the one thing that I've heard over and over is talking about all of the different facets of care that we need to have. And the one part of that that we are able to do internally is that hub and spoke model. So when we talk about fitness centers and we talk about physical therapy and EAP and on-site behavioral health services and all of those different programs, nutritional programs, health coaches, we have all of those. It's just that my team is the hub that manages and refers. We also do another thing called we call them our vendor huddles. And I know that that was mentioned a bit earlier, and we do them very frequently so that every one of our team members has a critical role in those soft transfers to the other services that may benefit somebody. So you obviously don't bombard someone, a newly diagnosed diabetic, you're not referring to EAP for the mental health part, the health coach, the fitness center, all on the same day. You're looking at what's appropriate in their journey to be able to refer them. So again, a little different perspective because we're internal, but we also manage and run our own leave of absence programs. So because of that, I also have that candid data point of knowing like what are our top illnesses that people are off work for. And as you would expect, it's the mental health, it's all those same old things, but it gives us a perspective and a lens to be able to direct programs at various locations or a specific country based on what those needs are. So that really does help. And our clinics are also staffed with nurse practitioners. So you get, and we really focus on that holistic aspect. It's no longer just the work-related injuries, illnesses, put the Band-Aids on, deal with OSHA and compliance. So we're way beyond that. All right. So, things to consider with chronic disease, and these are no-brainers. I'm going to run through my slides. My slides are very basic because I wanted to be able to focus more on the dialogue than really just what was on the slide. But what helps them to be healthy and safe in the workplace? Remembering that whatever they bring to the workplace is what they're also taking home. So however you can provide them with education, you're going to hear me say education a lot because I think it's super important. You don't just tell them once, you're going to have to tell them over and over, and it needs to be in different formats. And what are appropriate services to offer in the workplace? I had one of our sites in another country recently decided they thought that GYN services on site were going to be a good thing. Like, yeah, not quite sure we're going to go to the GYN part at this point. There are lots of other things you should be considering before we get to GYN. And then looking at that cost benefit analysis, again, doing certain things on site are super beneficial. Vaccinations, and I'm going to specifically talk about vaccinations in a few minutes because that was a big focus for us even from a COVID standpoint. But doing things on site to decrease that time away. So I heard someone earlier talking about how physical therapy, the time away from work is at least a 3-hour time. But what we found, it actually is probably more like 4 because they're going to stop and pick up their dry cleaning. They're going to grab lunch and they're going to do whatever other errands needed to be done as well. So because, our time is precious. If I'm already out, I'm going to get it done. So really looking at what can we do that's going to keep them the safest, keeps them in the workplace, and it's convenient. We also do know that our workplaces have changed, the whole hybrid piece. So how do we offer multiple things to get them in there on that one day and get the whole shebang done at the same time? So, we offer our HRA every year. We do their biometric screenings on site. We do our flu shots, our pneumonia shots. We do all of those things the same day so that they're there, they get one-stop shop, can get a lot of those things taken care of. And then how do we engage them and help them participate in those offerings to keep them healthy? We all know that group of employees that is always there. You see the same people every single time, but how do you really connect with the others that you really need to have there? And some of those are targeted communications. So we also know that in our manufacturing sites, they're not on the computer looking at emails and they're not dealing with that. They still want either e-signs that are flashing in front of them in the cafeteria nonstop, or a paper or a card that goes home. We've also been able to use our health claims, our medical claims data, as well as the HRA data to be able to have our medical providers, our benefits providers, send targeted messages to those that have maybe had some visits for pre-diabetes, have had other chronic illness and disease management concerns, that we can share with them all the other services that we have available to support them. And goodness knows, we have a boatload And we have about 6 different mental health programs, and people are like, why do we have so many? Because everything touches somebody in a different way. You could say the same thing 6 different ways, and somebody's going to get it this way and somebody else is going to take it that way. So we have found having that variety can be confusing, but as long as you're explaining it, it really does meet the needs in different ways. So again, some of the various on-site things, the on-site education, again, for me, it's the education of the what's in it for me, because just telling them why you should get a flu shot or why you should get your pneumonia shot isn't going to really help them. But when you start having those very specific conversations, and back in the day, I started in the employer space 26 years ago. And I was doing physical exams and health coaching and just the overall well-being type of events. Somebody had come in, was a smoker, African-American, increased heart rate, increased blood pressure, and in that pre-diabetic range. He didn't want to hear about anything about how it was going to impact him and why he should change his lifestyle and why he should do anything until I went down the risk factors. And when I got to things like, well, do you want to not be able to feel your fingers and toes? And what about going blind? And oh, by the way, you're not going to be able to have an erection. That was it. He was like, he got it. And 6 months later came back, was no longer smoking, and his blood pressure was under control. So it's those type, I'm not putting those on posters usually, but it's really what's in it for me. Like that's the message that he got. So how do you address those education points? Or, you know, if I don't get this, go to RSV. We know RSV is starting to hit more and more adults. If I'm not careful, then I'm not going to see my grandchildren, or I'm not going to be able to do that. So it's how do you make those really meaningful education pieces? On-site vaccinations. And that was something I was surprised I didn't hear a lot of discussion about today. And so that's, again, why I'll focus there. On-site health screenings, lab testing. Again, these are all things that can be done through the services you all have, because you guys can do it as a one-stop shopper, also using other vendor partners. Again, we manage most of that work-related and non-work-related inside our clinics. And then the other preventative and lifestyle programs that we've talked about, with whether it be Premise Health, whether it be some of the other organizations that are out there. So let's talk vaccinations. So I'm going to give you the whole COVID saga of what we did. So as a Pfizer employee, if you didn't already know, we kind of made a COVID vaccine, and we were in a very unique position because while the doses were controlled by the government, we went to the government to ask for an exception to be able to do our own internal vaccination program with our vaccine. So we looked at how we were going to do that. I will never forget it. It was December 27th of 2020. I get a call from the executive suite saying, you have 1 week to launch this around the world for our employees. No consents were made by that point. There was nothing. And we actually pulled it off, surprisingly enough. But we were able to do that. But you have to think about who you're vaccinating. What's the purpose? At that point, we had a lot of our sites that still have essential workers. We had research facilities that needed to have those labs continue. We had manufacturing facilities that are manufacturing very medically necessary drugs that if you had an outbreak of COVID, we weren't going to be able to take care of, and they were going to shut down. And so it took a lot of education. Again, you know what the social media realm looked like, you know what the news looked like, the social media is still crazy, like what's misinformation, too much information, etc. And so we spent a lot of time, it actually, the executive suite cloned it the Dr. Nikki series. So I actually did video clips that we would run on the e-signs. We would send through the overall email, post it around the world so that it was just clips of those misconceptions. How do we explain what the truth is? Am I magnetized? Do I have a microchip? Even down to some of those ones that were foreign and really funny type of things, but we addressed them because those were concerns. Even our own employees, from a trust standpoint, they trusted us as the employer. But again, when you're hearing all this information externally, how do you address that? We also decided that we had on-site contractors. So if our contractors that were working side by side with our employees on the line, if they got sick, now our employees are also going to get sick. So this was a one time where we actually did offer vaccination to our contractors, just like we did employees. You also remembered about March timeframe of 2021, getting an appointment for a vaccine was hard. It was not real easy to come up with those appointments. Healthcare providers trying to do this was challenging because, again, it was controlled by the states and by the governments. So everybody did something different. So we actually offered to family members and dependents. And how we did that was, again, some of you with your own clinic situation have like the resources at your hands to be able to, get certain supplies ordered, get a vendor, get somebody else that can partner with you, increase your staff to be able to do this. I had to find someone else. My team was nowhere near equipped to be doing all the family members. And we ended up finding a vendor partner that is used to going around and helping with national disasters. And they were able to do it. GMR is the name of the company. And they were able to come in and we did them as drive-throughs. So we still had them register online. We still had all the consents completed, but we did it all through a drive-through. So you just line them right up. They had a spot waiting for where they sat. Overall, with our initial vaccination program, we did over 200,000 vaccinations. And so it made increased trust, increased employee satisfaction because they saw that we really did care about them. And it wasn't just them, it was their families. Because again, you have to look at that trickle down effect. If I'm sick, I can't come to work. If my family member is sick and lives with me, I can't come to work. So we needed to do what we could to protect as many of those people. But then also, let's take it outside of COVID. What other vaccinations do we offer? What else makes sense? So we've traditionally offered flu shots, like no big deal, 12,000 flu shots in the US. We have 30,000 employees in the US, by the way. Out of the 80,000, the other 50,000 are ex-US. So we looked at what other things, like, yeah, we were doing flu, and we've always done flu, pneumonia, tetanus, MMR, and shingles. Like our clinics just often do that. We just have them there. We, the only ones we do big promos for though are COVID, flu, and pneumonia. The other ones are when you're coming in for a wellness type of evaluation or assessment, we're gonna ask you, are you up to date on your vaccinations? Would you like to get it today? Same deal, if you're up to date on your colon cancer screenings, here are the options. Here's how we weigh that. So we can give those referrals. We still do all of those type of managements from a wellness and prevention standpoint. But the vaccinations, I think there's limited understanding in what true value that brings to the workplace. But if you take that and look at how we operated in the lens of COVID, and really look outside of that, we don't want people coming on our work site sick. Because the moment they come in, it's like passing the plague along. So how do we help people to understand why vaccinations are important, why they're not the bad thing, why we're not trying to control them? People didn't think about vaccinations being really a bad or a controlled piece until COVID came along. And then it was all of a sudden, I don't want somebody telling me I need to have a vaccination, yet there are plenty of places where you had to have your other main vaccinations before you could work there. So again, education, how do we keep that all going? And then can you offer programs using your current staff or do you need to bring somebody in? For the majority of these other ones, it was easy. We used just our regular staff. I can run through 300 flu shots in an afternoon. Like I can just bring them in, walk them right through, it's all good. But you have to look at if there are any other complexities to what's going on. And can you offer 2 shots at the same time? So for years, we've done pneumonia and flu because they're able to be administered together. There's no adverse events to do that. Now it's, which ones do you offer? So right now, since the new bivalent COVID vaccine is out, we're going to be offering it at the same time as we're offering flu. And we'll postpone our pneumonia campaign till later in the fall, more like end of October, November. So it's just figuring out timings and when it's the right time. We've also done that same expansion of vaccination programs around the world. So we had a lot of sites that they weren't doing it. And it was looking at how do we, again, keep our employee population healthy and make as many services available equally, regardless of where you sit. You're still a Pfizer employee. How do you provide them healthcare? On-site test to treat. So this just talks about some of the other conditions. You guys have already talked about those today. The COVID one is probably the most interesting with the antivirals available. So what does that look like? We've talked to several telehealth, telemedicine, virtual visit folks. Not every provider will do the test to treat option. You know, antigen tests are readily available at home. Most people are not going to a healthcare provider to get a PCR test to then go through treatment. So how do we look at preventing the exposures of others? How do we look at that being able to treat? So we are using a lot more of the virtual visits. Our internal providers have the trust of the employees. They've been a staple and a stable force in our sites for a long time. So people are very comfortable coming to us, and we always did episodic care anyway. So this is just another way where we're able to put those treatment programs together. So I just threw these in here. It gives you a little bit of information of Paxlovid, which is our antiviral, but there is also the Merck antiviral. The big things with antivirals is all of them say symptoms can't have started more than 5 days. And the other part of it is you just need to know the health conditions and risk factors that go with any of the antivirals. Again, risk factors, kidney, liver disease, breastfeeding, certain medications. There's a fairly long list of those medications, so just be aware of those. And that list is very different between the Merck drug and the Pfizer drug. So just know what they look like. Some candidates that are eligible for Merck are not eligible for Pfizer, and vice versa. And then health education, just as a reminder, like I said, these are the things. Know what your health plan administrators can offer. We often don't reach out to them or push our health administrators hard enough to give us the programs that they have. We found out a lot of them had their own virtual health and telemedicine programs. They weren't volunteering that information until we pushed and said we weren't pleased with who was doing our telemedicine visits for primary care. And then also remembering, how do we send them reminders to stay up to date? So again, looking for ways to really keep people engaged and give those reminders and tips. Lifestyle, you guys have already talked about all the lifestyle ones. I'm not going to really talk much about those. Again, we use our health risk appraisal to do those pulse checks in the various locations. We have about an annual 75 to 80% participation in that. And I did forget to mention our US-based colleagues, the COVID vaccination program, we had 82%. And that was without any mandate, that was without anything. When we went to a mandate, we went up to 97.5, and that was without any accommodations. We did do accommodations, I don't want you to think, but I'm just saying we had 97.5 that were vaccinated, but 82% prior to anything. And that is it for me. Any questions?
So that was a great overview. Oh, hold on a second. Get microphone out to you. Not yet, not yet.
Hi there. First of all, I'd like to thank Pfizer for stepping up to save the world. And you guys did an awesome job.
Thank you.
I sold vaccines for 14 years, so I'm a believer. When in doubt, get vaccinated. So a couple questions for you. In such a mass vaccination program, US and global, in vaccinating, you know, the hundreds of thousands of employees that you have, were you able to track incidents of disease following?
Yes.
And any feedback on that would be wonderful. And then the second part of the question is adverse events. Receiving Pfizer myself, dose 1, not a problem. Dose 2, wow. Day after dose 3, So there lies my my question.
Yep. So thank you. The question of disease. So yes, we tracked that quite a bit, especially to find out, like, once we had offered the vaccinations, then we were asking. So my team was tracking. Again, it's only as good as those reporting, but for the most part, we were able to track our number of cases at a site, at a, you know, in a country, everything. I was keeping good pulse. I'm still tracking those numbers Every month we put a report together for our executives. So we did. We started seeing those breakthrough cases about 3 to 4 months in some of the cases after vaccination, especially with the initial series. So that was prior to any recommendations of any additional doses. And you'll not hear me say booster because I'm like, we're going to end up saying booster number 376 till this is all done. So initial series and then the additional doses. So prior to that, yes, we were starting to see some around that 3 to 4 month. Around the 6 month was when it was really coming to play. And what I was able to do is go back to our R&D team and our vaccine team and say, hey, just so you know, here's what we're seeing in our internal data. But we were still seeing a lot more of the unvaxxed at that point that were having positive cases. As far as the adverse events, so we have our own internal adverse reporting requirements, not just with the VAERS system for the government. So those numbers were plastered on every single consent form, on every communication, on everything. So I did not personally track the adverse events. That went through the safety team and the safety and compliance team like it was supposed to. So that was done very specifically. Obviously, if we were told of the event, I also then had a duty as a healthcare provider to have to report it. So that's normally when I'm like, I can't see anything on social media. I'm not listening to anything because you don't want to have to submit all of those reports. But yeah, what you experienced was pretty normal. It was your antibody reaction.
Other questions for Nicole? If not, thank you.
Thank you.
Wonderful. Thanks to our great panel here. So that concludes our first day of the forum. Tomorrow we start at 8:30. So remember that. Finish your bingo card. If you must leave an evaluation form for us. Here's a reception outside. Please visit our partners and vendors. We look forward